There are many types of labrum, tendon, and rotator cuff injuries and tears that surgery cannot help, or where surgery could even make things worse. And there are many types that can benefit substantially from regenerative patching.
There are many surgical contraindications and indicators of poor surgical outcomes for rotator cuff repair, and some of these still need to be better studied. Some of the studies that do exist don't do much analysis on pre- and post-operative size and morphology of the tear, and don't really group the patients and do subgroup analysis. But in general, most surgeons would agree that older age is a greatly increased risk factor of failure and poor outcome, usually over 50 years old, and especially anyone over 65 years old. And a lot of that is due to the poor tendon strength, which means there's an inability of the tendon to be able to hold an anchor and be anchored back onto the bone, or to hold an anchor without re-tearing. And so this can often be predicted just by looking at the imaging and seeing if there's degenerative changes in the tendon. Is there atrophy? Is there fatty infiltrate, cholesterol deposition, those sorts of things. With partial thickness tears, if the tear is small or less than 50% of the tendon, or if it's shredded, then it's unlikely that the anchor will hold well. And in most cases, that can be debrided, but to actually do a repair, oftentimes you need to cut the remainder of the good tendon and pull it back onto the bone, which means there will always be some portion of tendon that might be weaker than it originally was without doing any surgical intervention. And with full thickness tears, if it's only a thin portion of the tendon, even though it may go all the way through the tendon, it might be one little fiber of the tendon that retracts or tears, and that's not going to be able to hold an anchor either. And then this leads to another kind of soft contraindication, which is shoulder stiffness or adhesive capsulitis. These patients tend to have poor surgical outcomes as well. So in general, there are many factors to consider, but ultimately you really want to look at the size and morphology of the tear. And in one study, 20% of surgical repairs actually resulted in re-tearing, and these patients ended up with an even larger tear after surgery than they started with. And that can lead to catastrophic outcomes. If it does heal, it usually takes years, and it may never fully recover. So minimally invasive regenerative interventions can be used to stimulate and enhance rotator cuff and labral tear healing and recovery. I do these under minimally invasive image-guided approaches, so there's fast recovery. There's really no downtime at all, just a little soreness from the needle injection approach. But other than that, we just rely on the stem cells to do their job and integrate into those tissues and repair them over time. This requires a good analysis of the 3D structure of the tear for the best approach and for how to best fill in the defects and patch them and stick them together and get the best possible outcomes. And this is why I also use image guidance, where I can see submillimeter resolution, whether it's articular or bursal-sided tears, the depth of tears, the width of tears, intrasubstance tears, and I can look from every angle. And in some cases, when necessary, I can also use a scope to see direct arthroscopic views for the stem cell patches. And it's important to note that you can do both options. This isn't an either-or decision. You can choose to do regenerative agents before surgery to get the most healing possible with a much less invasive approach and potentially avoid the need for surgery, or you can do it after surgery to aid the recovery process and optimize healing strength. So again, ultimately this depends on many different factors, including the patient's age and condition, but most of all the features that we see on imaging, and that is primarily the 3D structure of the tendons and the tear and the morphology of the tear and the defect, with the ultimate goal being to obtain the best outcome possible regardless of whether surgery is done or not, but hopefully avoiding surgery and a long recovery. And I've seen many patients be able to make a full recovery, regaining full strength and function with these regenerative repair approaches without having to resort to surgery.
One unique thing that I do that helps optimize outcomes of stem cell therapies is to embed them and mix them with a scaffolding matrix. And when I do this, I mix the stem cells in, especially these mesenchymal stem cells that come from bone marrow, which are primed to become orthopedic tissues. I bind them into these hydrogel matrices, these protein matrices, which help to stick the stem cells right where I inject them. And that prevents the stem cells from diffusing and disintegrating and dying off and undergoing a process called anoikos, where stem cells will essentially just die off, similar to a programmed cell death of apoptosis. These stem cells, they want something to grab onto and to live and thrive on and proliferate on, and that helps integrate them into the tissues. So the fibrin scaffoldings are really good because they're like a sticky matrix that helps stick to tissues. It gives the tissues a matrix of growth factors itself. Plus, in addition, it holds the stem cells there to help bind them and localize them and integrate them into the injured tissues.
Regenerative stem cell patches make a lot of sense to give a scaffolding to bind in the defect and give something to rebuild on and strengthen rotator cuff tendon and labral tissues, as well as to diffuse growth factors over time.